We have to go. So, today dedicating the diet of the pancreas and, of course, diabetes. So, to start with and there's not a ton of information from Welsh Whole, your textbook book, but there's some. Nevertheless, straightforward. Pancreas is essential. It's an organ you got to have. Can't go along with that. Does double duty. We're going to cover it again with digestive. That's its exocrine function. It goes by way of a duct, eventually leading to something called a common bile duct or the hepatopancreatic duct, as it's currently named. And its exocrine, that's its exocrine function. Its endocrine function, what we're concerned about, insulin and glucagon. And it's interesting because there's almost not simultaneous, but almost a contemporaneous type of release. So effectively, it's part of the homeostatic mechanism to release them and to avoid severe ups and downs. I'll give you a little idea about what that's about. The way we used to evaluate diabetes, a little bit different today because we have a little bit better technology for things like that. And so they give you the idea of, and this is our exocrine. These are called the islets of Langerhans. There's 3 areas. The function of somatostatin is again, is it not 100% clear? I would think from when I've been doing some additional reading, it certainly plays a role when food enters your duodenum because it basically stops growth hormones activity and allows insulin to flourish. By that time, insulin has already been secreted. That's there. Insulin, very famously, beta cells of Langerhans or Langerhans, as it's pronounced, and it decreases blood glucose by targeting nearly all the cells in your body, creating a chain of events, one of which is to allow for the facilitated diffusion, because there's always more glucose outside than inside, because it's immediately changed once it enters the cell. So it's always going to be more outside than inside. And it's our basic mode of energy transformations. Okay, utilizing carbohydrates and carbohydrate-like products as a source of energy. And then glucagon works on the liver. And what does it do? It causes a release. It increases blood glucose into the bloodstream by way of the liver, and it targets glycogen. Glycogen is the only way we can store carbohydrates easily, and it's only in skeletal muscle and in the liver. And as I've said to you a number of times, that's sort of like your emergency supply. What it's doing here is because when we look at utilization curves of sugars, they don't go, it's not drastic ups and downs. When it does things like that, it suggests a problem. When we're going to look at diabetes, you and I call diabetes, which is appropriately named diabetes mellitus or mellitus, depending on who's pronouncing it, or sugar diabetes, anytime we see irregularities in sugar metabolism, excessive highs, excessive lows, dramatic changes, irregularities, prolonged events, all of those suggest either someone's a diabetic or going to become one. And there's a tremendous amount. You can go crazy with this. We could dedicate a whole course on diabetes and not be able to finish it, much less in a semester or a year, easily. That's how complex. And I'll say it again and again to everybody sitting in this room. If you're going into a clinical field, I know not all of you are, but if you're going in a field dealing with sick people, most common diagnosis you're likely to see if you're dealing with an adult population, diabetes. It affects so many things. And the anatomy is really straightforward. This is the ductal system. That's the common bile duct. Has fancier names these days. Here's nothing here. Glucagon, liver, glycogen, increases blood glucose, insulin everywhere. All the stuff. Insulin has, as you can see, a dramatic amount of effects. Okay, lowers blood glucose. Not clear. I think a lot of it does have to do with its impact on growth hormone myself. You're just summarizing all of these things here. So there's not a lot to say. Now I get to the important part. Metabolic disease resulting from one of 2 types. They are not so good in this textbook dealing with the ins and outs, and maybe the other textbook that I use, Marib, is maybe a little bit better, but there's a lot of information with this, and I'll go relatively quickly a lot of it, when I start getting to this, is not necessarily something you're going to see on this exam. I Important to listen to it. I mean, I'm not expecting you to become a diabetologist overnight, but it's just something you need to become familiar with. A lot of times that's a turnoff. I want to punish my tongue for saying it. When I say it's not going to be on the test, because students have a bad habit of shutting it off. Okay, so please, long run, because there's somebody going to be in your orbit. It's going to be a diabetic, much less a patient. So results from either problem with the insulin, not enough being made, something wrong with the way it's being made, a fault in insulin manufacture or delivery would be a way to look at it. And then, or cells can't use the insulin. What's going on here? Usually that's a problem with the receptors. Okay, that breaks you into the two types. When it's insulin related, we call it type 1. When it's the receptors on all those cells related, we call it type 2. It's gone by a lot of names over the years. Years ago, we used to call it youth onset and maturity onset. We find that those are misnomers. Okay. Now we typically utilize type 1 and type 2, or we'll say insulin dependent and non-insulin dependent. And all of those have inherent faults. You can't, there's no way to, when you have someone with diabetes, there's so many factors that are involved. It involves all of their systems, and you have to treat it very aggressively if people are going to survive long haul. And what we have, and the biggest problem when they talked about, well, if somebody very young got diabetes, we know it's an autoimmune based disease. There's a variety of reasons that I'll sort of talk to you a little bit about with regard to it. And the interesting thing is that they used to think, well, if this happened to anybody under 40, it was going to be this youth onset or insulin dependent. Not the case. You can get that later in life. And the type 2, oh boy, this is the biggie. We call it maturity onset. All of a sudden, for some reason, they're making insulin, but it's not working. And they say that just happens, people, they, sitting there popping, candy and processed sugars and all that type of stuff. Oh, they just like burned out their receptors. Any way you want to describe it. Well, guess what? It's not necessarily what happens. It isn't confinement. That's one of the biggest problems that we see today. It's called Syndrome X or metabolic syndrome. It's little's the wrong term. It's people, it's kids, younger children, teenagers who have become very sedentary. They sit in front of a computer. They play video games. They don't do active sports for a variety of reasons. Their diets are horrible. That's the good news and bad news about being a country with a relatively large amount of wealth. Okay, you don't have to go out there and dig in the fields. You don't have to do all those things. So we've seen this, and this, tremendous problem with being overweight. Weight is an extraordinarily large problem in this. That's the problem when you have a developed country and you have adequate resources and food supplies and all sorts of good stuff. Okay, what do we do here in the college? We want to get people to come to an event. We want to get them to come to a speaker. Here's what we say: feed them, they will come. That's how it works. Hey, we're having pizza, we're having snacks, we're having this. We're just trying to get people. Great. Maybe they'll show up. So you won't be speaking to a room of like 2 people. It's the way it works. So, elevated blood glucose, tremendous amount of systems. We'll get into it a little bit how it works. It disturbs not just carbohydrate metabolism, but think of what happens. We can't use carbohydrates, then we have to start breaking down proteins, and oh boy, we got to start breaking down fats, and now we got a problem. Because those fatty byproducts, keto acids, trans fatty acids, ketone bodies, they are very, very damaging to blood vessels, particularly small ones. And what that does is it creates deposits, which eventually cause limited circulation, eye, heart, kidney, nerves. Leading cause of blindness, diabetes. Leading cause of kidney transplants and people on dialysis, diabetes, 75%. I can't even imagine the amount of statistics for those having heart disease or heart attacks or have had stents and things like that. Diabetic peripheral neuropathy, about half the patients, they can't feel their feet at all. They burn themselves. I had patients who would come in, try not know. All of a sudden, I got blood coming out of my shoe, and I see he was a carpet layer, a giant carpet tack, and they didn't feel it. I was didn't feel it. Operated on a guy, took out bone in his ankle. Not a feeling whatsoever. No anesthesia necessary. Thank you. Absolutely insensate. These are things that happen in my practice. Again, maybe 65. Sure, more than half the patients, probably 60% or more of the patients were diabetics. A lot of them elderly diabetics. The gentleman with the bone was not my age. When I started treating him, he was a few years old. I was born in 1948. Unfortunately, he's no longer with us. Every doctors have favorite patients. He was mine. Okay, so high blood sugar. Cells have to go to other sources of energy, and as you can imagine, you've got to gobble up other resources. You're not using your resources effectively, and there are different things. The declination in weight is not necessarily true. Okay, even though you're gobbling up things, a lot of times you're eating additional alternative sources. I mean, because your craving for carbohydrate didn't go away. Your body says my sugar is low. You find carbs, whether they're complex carbs, whether it's pasta, whether it's bread, or whether it's simple carbs, okay, like that. So yes, there's hunger, fatigue because you don't have energy sources. I'll go into all of these in a second. Real problems with healing. At the base, diabetes in many instances has a lot of immunological implications. Some of the healing is inadequate circulation. Some of it is immunological in nature. When anything that compromises your immune system is going to impact your healing. Very, very much so. And I mean, I have a lot of information vis-a-vis wound healing. We're even going to talk about that in the next chapter we do, which is for the next test, the blood chapter, where we're going to talk about something called platelet-derived growth factor, which is really one of the implementations in wound healing clinics. Okay, and we're going to see what happens when there's too much sugar. Your kidneys have a limit. Okay, that's why it's so important. We're going to go over this kidney as well and other things. Your kidneys normally, if your normal blood sugar is what? About 65 to 110 milligrams percent. So if you do a random blood sugar for any of you, assuming that you're not sitting there gobbling down 2 candy bars in the last 5 minutes, okay, likely, or just had a really big carbohydrate-laden meal within the last half an hour, it's going to be in that area. And typically, a lot of times we'll do that fasting. Do it fast overnight, we'll get fasted blood sugar. It's going to be somewhere in that area. That alone it doesn't guarantee that you don't have it, but it should make you sleep a little bit easier. Your kidneys, if that number gets to 185, and now we're getting a pretty poorly controlled diabetic, the kidneys can only reclaim that 185 number. If it gets over that, let's say it gets to 200, it starts to spill into the urine. That's what they're talking about here. Called glycosuria. And just like the ever popular Steins, Mary had a little lab rule with sodium. Water is sure to follow. Anything like that, any solute, water is sure to follow you. Sure to follow by osmosis, leading to dehydration and thirst. So from this, we get sort of the hallmark. I don't know how I can. So you get this. Because you're getting more, you get polyuria, more liquid. You're going to expel more coming out in the urine. Okay, it's going to make you thirsty. I'm telling you, right? So more your urine out, your amount of urine you're putting out increases. This increases your thirst. You're losing sugar, so your body gets hungry. polyphagia. Those are the three big polys. And then lastly, and certainly not least, if that's a word, fatigue, because your ability to make ATP, energy transformation, is reduced. Goes down. Those go all over. It's vicious. It's a syndrome. It's not one specific thing. It's a combination of things, and everybody's different. So that, and what happens, the longer that number stays here, elevated, and you're spilling, the ability to retain the urine lessens. So that's why it's so imperative when we get diabetics and they're at a big number like that, you got to bring them down, because what happens, the more it's above that, all of a sudden the ability to bring back the sugar down to 175, 160. Okay, you're clobbering the transport mechanisms. That's why you'll hear, many of you are going to be in contact with endocrinologists and diabetologists, aggressive sugar control early. And it's a family affair. When somebody's a diabetic, you get everybody involved. Oh, I saw you, snitching that candy bar. I used to do house calls all the time. Candy bars. We only have one link, really was one to diabetes. I'm trying to make sure she doesn't lose the other one. In her nightstand, I like mine, Twix bars everywhere. Hey, between Kit Kats and Twix bars, I'm a happy person. I'm not the only one in this room who likes those. You guys are skinny. I know, Addie, I was not talking about you. You are skinny, but I wasn't making the accusation that you were a Twixaholic.
No, I love Twix.
God bless. It's a kindred spirit. I know. She's the world's best audience. What am I going to do with you? Diabetes mellitus, juvenile or insulin dependent? Yeah, not anymore. School's out of that one, everybody. Autoimmune disease. Some people think it's viral oriented. Why are we certain? Because people with diabetes long term, we didn't have a name for it. Okay, we call it you don't have to know it. KW, or Kimmel style Wilson. What it was classified as, we saw deposits in the kidney of protein, and that was killing the kidneys. So we saw that with diabetes, high blood pressure, because it's hurting the kidneys, and these deposits in the kidneys. Later, when we began to be able to analyze, we found that these were antigen antibody complexes. You'll see when we get to the immune system portion of the program, after the break, what you're going to see is that characteristic of autoimmune diseases. Antigen antibody complexes are one way where they damage tissue. Famously, there's one called systemic lupus erythematosus. It precipitates out in a variety of different organs and causes significant damage. The kidney is just one example. That's the underlying reason why we're very confident of it. When I first learned about it, they didn't know this. We knew it was there. We knew it was a bad condition with diabetes. It was something that we look for, but we didn't know that underlying it. When I learned about diabetes extensively back almost 50 years ago. That's why doctors, nurses, healthcare people, we go to conferences. We go to continuing education all the time. A lot of times you have to do that to maintain your license. Nurses generally not, but they should, unless they have changed. A lot of times they'll get that from in-services and things that are being done in the environment that you're practicing. For doctors, we have to take a certain number of credits. And there's different categories of credits that are involved. It's changed. I haven't maintained my license in nearly 25 years. So 5 to 10% of the cases are type 1. I don't know about the numbers. It's either lack of insulin, faulty insulin. Type 2 used to be this. I don't know if it's that dramatic a difference, but it's a fair, I would say there's more. Insulin is produced, but I think that it's less about the fault of the insulin as it is in the receptors themselves being able to respond to the insulin. It is not mild. We know where they got all of the complications are there for both. It's ludicrous to think that what affects one doesn't affect the other because the end product is the same. You can't utilize sugar, so you got to utilize fats, alternative sources. You can utilize proteins, and then you end up with a bunch of nitrogen you have to deal with. But by and large, your body does this. Sugar's favored. If there's no sugar available, we do fats. That's the principle of ketogenic or carbohydrate sparing diets. The one that most recently had me lose about 40 pounds from where I was 2 years ago. If you'd come in here this time last year, okay, a year ago. So the principle of the ketogenic diet program or low carb diets is if we use very limited carb intake, your body will utilize fats, assuming your kidneys can do it and use healthy fats, you drink a lot of water, good to go. It works with a lot of people. For me, it works great. A lot of energy levels and things like that. I'm not so good right now on it. That's why that's right. We went out and got the pizza last night for the not so Super Bowl. Sort of a misnomer last night. Unless you're an Eagles fan, and that's fine. Hey, it's okay. Nobody's perfect. Next, you use fats. And once you start using those fats, that's where the problems are. Because your body breaks down fats and gets a lot of these toxic byproducts. If once the fats run out, now you start to break apart proteins. That's a big problem. Now you're in the stages of malnutrition and you're starting to really end up with significant problems that are there. So yeah, need insulin for sure. Typically today we use recombinant DNA, genetic engineering, if you will, genetically altered back. It was the first genetically modified agent. Insulin, 1977. It came out as Humulin, human insulin. I had just graduated that year. We were just hearing about it in the hospital. All of a sudden, the folks treating the diabetes, we're going to start using, put Mrs. So-and-so or Mr. So-and-so on Humulin. Okay, it was new. Because other than that, it went from pigs and then went to cattle. Pigs, there were a lot of allergies more so of. There were a lot of religious implications for a variety of faiths that didn't utilize pork products. And then, so cattle was used probably more extensively there. Now there's a whole array of things to use it. I've had student athletes who have done great on insulin pumps. Okay, injection is the most common way that it's utilized. It's there. The reason why you have to do things like that is it's not orally active. Okay, it'll be destroyed by stomach acid. So, and a lot of times when you see things that have to be given that way, that's because the acidity in the stomach will clobber. We get to that a little bit when we do that. Skin patches are great ways to give medications. Okay, most people are familiar with them with nicotine patches because you can identify very specifically how much is going to be absorbed over time. It's a very reliable rate. We use fentanyl patches for long-term pain control. They've been around. Patches have been utilized for blood pressure and sometimes heart control. And this is something new that I'm unfamiliar with. Type 2 diet is lifestyle. Exercise. There are a lot of medicines now. This is where, what's the name of that crazy medicine area? Ozempic? Is that this whole category I don't know a lot about. The trouble is when you find something it has that apparently a desirable side effect. Everybody's looking for a wonder drug to lose weight. I eat what I want to lose weight. And it's always been around. Down the road, because it's relatively new, they'll find problems with it. I always worry for folks who have used it extensively, what's going to happen. Because it's really not a substitute for lifestyle changes. Lose weight, stop smoking. I used to joke, go to my family doctor. She's a wonderful lady. She still practices over at St. Margaret's. I'd laugh. I'd see her. And I'm at the front desk as she's walking by. I said, "Hey, I put $20 down. Here's my copay. Lou, lose weight, stop smoking." And I start to walk out the door. She goes, "Stop." She always told me the same thing. Lose weight, stop smoking. And so all the and yeah, taking the step of gastric bypass surgery is not something that people should look at lightly. So there's a variety of different ways, and I do not understand the way that some of those agents. I probably should do a little research and share that with you. Give me a project when I'm not busy with a wedding. That's all they said about it. They could have talked a little bit more. Moving on. Hold on. So this is the other PowerPoint. So we can address this for about 20 minutes and see what I come up with. How else do they deal with it? I'm just curious. Is there anything else? There we are. How do you know if somebody has diabetes? How do we monitor it? How do we monitor how well they're being maintained? Whether they're doing diet, exercise, whether they're getting insulin, whether they're on some oral medication.
Check their A1C.
They check their A1C. Excellent. Anybody ever hear that? Hemoglobin A1C. Hemoglobin A1C is called glycosylated hemoglobin. So hemoglobin A1C, and I forget the norms. It's around what, around 6%? And understand your red blood cells are carrying a certain amount of sugar. That's what glycosylation is. If you're being treated for diabetes and that number is going down, it's good. The number is going up, it's bad. So it's really and so the way today, the way we diagnose diabetes is we look at sometimes random blood sugars, sometimes fasting or random blood sugars. Obviously now we have the technology. We use it all the time. Everybody knows somebody who can prick your finger, have it at home, stick the little thing in a little battery-powered device, get the numbers, it'll save them. Diabetics use it all the time. Glucometers have been around. And then at the same time, they'll be monitored by this. So between random or fasting blood sugars and glycosylated hemoglobin, we can keep pretty good track. And a lot of that has become the diagnostic criteria. Years ago, we didn't have that. So we had to do something, and it's really very beneficial. It's called the glucose tolerance test. Sometimes you have to do it for 7 hours. Basically, you had blood sugar, and the x-axis is scientifically time. So at time 0, we do a blood sugar. Let's say it was 65. Oh, sounds great. This is like half an hour, 1 hour, 1.5 hours. Normally you would do it for 2 hours. So you get what the norm was, and in that half an hour they get a test load of about 100 grams of carbohydrate, CHO. This isn't to memorize, it's just try to explain how we used to do it. Typically you'd have like 20 minutes to drink this like orange or cola flavored. Like you can hardly get down one of those 60-way sweet things. So that's a lot of carbs. You see how your body would utilize it. Which you might guess, all of a sudden it would go up, let's say all the way here to 170, and then if things were normal, it would go down. In like 2 hours, about 2 hours, it should be back around to that normal range, 65 to 90, that area. Gravity slow. But it kind of looks a little down, and then the overshoot coming back and kind of get like that.
Is that how they test for gestational diabetes?
Yes. Everybody hear that? Gestational diabetes. When a woman is pregnant, you're putting out a lot of glucocorticoids, like we had discussed earlier, that elevates your sugar. That's your response to stress. A lot of cortisol is related cholesterol-based products, one of which is cortisol. So they have a lot of that glucocorticoid activity. And that will develop what's called gestational diabetes. Someone who is technically diabetic during pregnancy, and that, if they are, then they are by definition now a pre-diabetic. Pre-diabetic, we have heavy babies. Years ago, it was a baby who was over 10 pounds. Now it was over 9 pounds. Because like when I was a kid, I was mom. There was no restrictions on how much to eat. Oh, gain all the weight. Now, obviously, that's changed. So now the criteria is 9. Is there a relative in your family, a close relative, one relative, parent, grandparents, diabetic? Okay. Or going back to that, that's where that glucagon comes in. If you have one of these where they're making all of a sudden sharp turns like that, okay, it's called reactive hypoglycemia. It shoots way down. And ladies and gentlemen, high blood sugar is a big problem. It can be treated. It is by not any reason. If somebody comes in with a 500 or 700 blood sugar in the emergency room, we're going to get that down. That is not a life-threatening situation. Low blood sugar is. Your brain only works on glucose. When it gets below like this area, 50 and below, your brain will shut down, bang, like that. Low blood sugar is the emergency situation. That's why diabetics carry sugar supplements. They have something to stick under their tongue. They might have a special kind of a candy bar or something as they start to feel shaky. There's all sorts of things that go on with it. So that's all part of it. That was a very good question. So that is gestational diabetes. It's really something, and you have to consider that with patients, and many of you go into maternal trials. And sometimes it isn't clear, it's suspicious, and you bring it out to 3 hours or to 5 hours. And they still do these tests. Not just for the pregnancy aspect, but just to try to get an idea, particularly if somebody's a pre-diabetic. So I've been kind of fortunate, having had a diabetic maternal grandfather, and my mom's brother became a diabetic probably in his 60s or so. And so thankfully I have missed that particular boat. So my sugars are pretty good. The reason I'm still here, is my wife. She got me on the straight and narrow. Same kind of stuff. Glucagon. So there's a lot of things that do this. Again, it's an emergency. That's fight or flight. That's that emergency supply. So you don't have to go crazy over it works on the liver, raises blood sugar. Insulin works everywhere, lowers blood sugar. That's the kind of stuff you need to know. Insulin is a protein. Proinsulin means it's inactive, it's modified. We actually shorten the chain that's there. So lowers it by glucose in, okay, stops that glycogen from being broken down, okay, inhibits the conversion of amino acids or fats to glucose. So it's all designed to utilize sugar and carbohydrates as your energy source. Not needed for glucose uptake in liver, kidney, or brain, but it's the only thing the brain will deal with. All of these things are important that are there. The enzyme system, when we go into it, I do this to the advanced people, it's called tyrosine kinase. It does a lot of stuff. Okay, generating energy, actually creating more glycogen for muscle and for liver, converting glucose to fat. Okay, what happens there is when we have, if you make ATP and you don't utilize it in about a minute, it's going to start to make fat cells. We've got to be so careful dietarily with things like that. You can just go down to calorie counting. We use about 2,000 calories a day, however you want to slice it out. Some people are just not troubled by stuff like that. I mean, some people just can eat what they want. I go by a bakery, I sniff, I could gain 2 pounds. I'm sorry. I'm just one of those. My sister is anemically skinny. I told you, she weighs the same as she did when she was a freshman in college. Like 97 pounds. She couldn't be 80 in October. Oh, my husband, we both weigh the same as we did in college. Oh my God, I can't fit into my size 4 anymore. Why? Oh, it's okay. So, factors that influence it: prolonged blood glucose high. Okay, more of the other stuff in there. Okay, play a role. Parasympathetics kind of keep, again, sympathetic versus parasympathetic. Sympathetic slows down insulin, parasympathetic increases it. All of these kinds of things when they're active. Again, this is fight or flight, and growth hormone is always going to oppose it. Okay, a lot of thyroid hormone will oppose it. Those glucocorticoids. That's one of the problems with the pregnancy aspect, where we begin to see this outpouring and irregularity of those things. I mean, I had the glucose tolerance test years ago before we called it South Beach or low carb or Atkins, all these different diets. Now we call it ketogenic diet. It originally came out with a diet that was being used, and a limited number of doctors had it. We're talking about the early 80s. And I went on it, and before they would put you on it, they had to make sure your kidneys work, so I had to do a glucose tolerance test. Of all places, in Meadville, I went to see that doctor. Go figure. So voila, here we are, type 1 and type 2, dipsy all the ones I wrote. Okay. In diabetes, fats are used causing lipidemia, excessive amounts of fatty acids. They form ketone bodies, keto acids, and that's where in the problem. Now, by utilizing that and having this degree of acidosis, if you learned nothing, you learned about two things that influence proteins denaturing: temperature, pH. Acidosis, you're going to start to slow enzyme reaction down. When they start to denature, they don't work as well. So you have less than optimal things going on in your body. And what happens, how do we detect it? We find ketones. See, the ketosis or ketone diets, the keto diet, which you're just trying to achieve that. But you have to have kidneys that work, and you have to flush them out with a lot of water, and the fats you have to eat have to be healthy fats, not bad fats. Okay, that's the goal of the exercise. You can do a stick test and certainly a urine test to see if you're in ketosis. And if you look at any of the videos, that's exactly what this. We have that system at home. We did it pretty seriously. I went from 237. This is back before the lockdown in 2020, from 237 to 177. But then so much pizza, so little time. I mean, so much food, so little time. All of these things. So what you'll see in diabetics, when they're out of control, they have ketoacidosis. You can smell it on their breath because they get acetone breath. Keto acids give you acid. It smells like they're drunk. And a lot of times someone will be like that and they'll be arrested. I've had so many diabetic patients who said I could miss my appointment because they had me in jail because they thought couldn't feel their feet. They're walking like this. They thought they were publicly drunk, smelled their breath and say, "Oh, you're going." And then all of a sudden the blood test comes back and go, "Wait a minute, it's blood sugar. It's not alcohol. No alcohol, but a bunch of blood sugar problems." And so, and really, this is what happens. So they get Kussmaul breathing. The breath is profoundly smelling bad, hard, and all of these. Now you start to do enzyme systems, oxygen transport, but it happens gradually and slowly, progressively, as opposed to low blood sugar, dangerous. It can be like that. I've had patients where all of a sudden, and typically here's what they do. Well, I took my insulin in the morning, and they said, "I'm running late to work. I'll get in the car. I'll grab something as soon as I get to work." Next thing, there's one guy, what I was telling you about with the bone was so bad. All he remembered was I somehow got to work, and the next thing he knew, I woke up in the hospital. It was Titusville Hospital, in northwestern PA. And, and it's just like in the movies. They give him some sugar. It's like, where am I? And he, it's say somebody found you in the parking lot where at his workplace. Scary, absolutely. And I can't tell you how. By sheer luck, it didn't happen when he was in the middle of town, right during school hours. School bus hours with the kids. You could have easily run over somebody, hit somebody, hurt yourself, drive into a tree. You figure it. So there are other things. You could have excessive insulin production. This is another one. This is where hypoglycemia, very, very quickly disorientation, and that's why it's kind of a crapshoot because it's some people are extraordinary. Some diabetics are easy to treat because they're stable. He was very, very labile. Labile means irregular. See, we see the same thing with blood pressure people. Some are easy to treat, some are hard to treat. And it was a shame. I'll spare you the chart. I'll spare you that. So that's kind of where I wanted to head with all of this, to give you some insight into what's going on. And the real problem that we're seeing today, for whatever reason, we are seeing so-called youth onset or type 1s, insulin dependent. All of a sudden, we're seeing people, for whatever reason, their insulin, maybe it's genetically pre-programmed. So later in life, they're having to, and sometimes they have to utilize insulin. So it's not magic. Somebody over 40 or 50 finds out they're a diabetic, may have to utilize insulin because a lot of times the so-called maturity onset ones, well, that oral medicine isn't working, so we better put you on some insulin. So understand there's a blend. But the one thing I would tell you about more than anything else is this metabolic syndrome or syndrome X that we're seeing so many of. And it's been around for a while. And that is what is the consistent signs and symptoms of maturity onset or diabetes with this inactivity, lifestyle related problems. And so people in your orbit, it's very hard because societally speaking, we just don't do enough physical activity in this particular kind. It just has to do with it. There's such a big problem, and it is weight related for a lot of people that are there. I'd have been curious to see how it would have affected it. It's the weight in our family was on my mom's side, which I tended to favor much more so, where on my dad's side it was not. That was there. They was more. They were tall and skinny. What happened to me? Go figure. Two first cousins, 6'3" and 6'4". Is that fair? My dad was 6 feet tall. Is that fair? Oh, thanks a lot. So it's hard to figure out. So, so if I had biological children, I'd be very interested to see, but that wasn't the case. So what are you going to do? So and that's really what a lot of this is about, to begin to understand the ramifications of this extraordinarily strange disease. Years ago, we used to think it caused what was called basement membrane thickening. If you remember back to, I know this is a while ago, to all those tissues you did in the lab, if it's a lining tissue, epithelial tissue or lining tissue, it's on a base layer called a basement membrane. We used to think that would thicken with deposits. I think we're a little more sophisticated and understand that the blood supply directly underneath it is really where the problem was. That used to be one of the hallmark things you would look for diagnostically in biopsies and things like that. But now you begin to see them differently. And those basement membranes typically were in arterioles. Where are arterioles? Are tiny, and we're going to get to this. You're going to get to a lab. We're going to do it in a lecture as well when we start getting into blood vessels. Arterioles are microscopic arteries where we begin to see the ability where deposits in those can clog them. And so these are typically, we now know it's very much inflammatory. It's sort of going not in the line, it's under the epithelial cells. And as you're going to see down the road, there's smooth muscle. In between the smooth muscle and the lining cells, there's loose areolar connective tissue and collagen. And that's kind of where the process is. And it's inflammatory in nature. And that's where things like aspirins a day help. They stop platelet aggregation. They're somewhat anti-inflammatory. If your stomach can tolerate it, ibuprofen would be the same thing. Naproxen would be the same thing. So there's a lot that goes on. And those tiny vessels, where do we see them? Capillary beds, your eyes, your kidneys, around your heart, around major organs. And that's where the data is. Well, I'll leave you with that. Thanks for letting me spout on about diabetes. So I sent you a recording. I'm going to start sending all these things just YouTube and send it. It's easy. It seems that they're working. That way, not embedding them, but just sending you the YouTube link. Listen as much as you want.
No, you're not bothered with requests.
Oh, I don't want to have 1,000 requests. Drive me nuts. I like talking to you, but I'm trying not to take my computer with me. Okay.
You want free time.
No, not
What?
necessarily.
You want
If you don't
free
have
time.
something-
I